Hi, David Rosenberg here for the Psychopharmacology Institute. In this CAP, or Child and Adolescent Psychiatry Smart Take, we'll look at a growing big concern, specifically the significant barriers that limit adherence to clinical guidelines for metabolic monitoring of second-generation antipsychotics. In this article, Aurora and colleagues actually get the psychiatrist's perspectives of what the barriers are to adequate metabolic monitoring in youth treated with second-generation antipsychotics. This is a huge issue as prescription of second-generation antipsychotics has skyrocketed at a rapid rate for more indications. While these medications can benefit many, there's growing recognition of weight gain and metabolic syndrome complications, which are more common in youth than in adults. In fact, youth treated with second-generation antipsychotics are 2 to 3 times more likely to develop type 2 diabetes. We also know that early metabolic monitoring is absolutely critical for early identification and potential prevention of weight gain and metabolic complications. I don't start these medications without first talking with the child and family and explaining the potential side effects, the need for monitoring as a condition of being on the medication, and how important it is to have a regular exercise regimen in place when you start these medications. Delays can also have potentially lifelong consequences. So paradoxically, as prescriptions of second-generation antipsychotics continues to increase, adherence to clinical guidelines for monitoring is inadequate, so best practice guidelines are often not being followed. So it's critical to determine what the barriers are and how we can overcome them and get around them, as not doing so puts the children we serve at great risk for lifelong complications such as diabetes that also have significant morbidity. So what were the biggest barriers to best practice and that are putting the children we treat at risk? A big one is lack of adequate resources to actually do the necessary monitoring. For example, our outpatient clinics and inpatient clinics are either hospital-based or hospital close, which definitely facilitates monitoring. A lot of non-hospital-based clinics, physicians' offices, physicians in private practice may not have this kind of access to even standard equipment like blood pressure monitoring, scales to measure weight, waist measurement tapes, and so on. Other barriers that need to be overcome include caregivers' lack of engagement in the treatment of their child. And remember that patients with the disorders we're treating with second-generation antipsychotics not uncommonly have parents with psychiatric illness, such as depression, which can present a barrier to engagement in their child's treatment, follow through, having motivation to do so. We know, for example, parents with depression can have concentration impairment, challenges with focus, be overwhelmed by their own symptoms, have a lack of energy and motivation. To be fair, in some cases, we don't make it any easier for our patients and caregivers to do this, even those who are motivated. We know that children and even some adults are not very fond of getting their blood drawn, which is critical for adequate metabolic monitoring. Maybe if there's any silver lining with COVID, we're getting somewhat desensitized to shots and needles. Seriously, though, for children, this can be a big problem, especially in children who are needle phobic. I know physicians who will try not to prescribe these medications, especially to avoid the necessary monitoring. And obviously, that's a problem when medications that are used to treat serious conditions like bipolar disorder, psychosis, schizophrenia, and so on are avoided that can potentially do enormous good because the necessary monitoring can't be accomplished. There can also be problems in communications in offices that do this with disorganization or lack of appropriate reminders, lack of adequate staff for when monitoring is needed, confusion about who in the office is doing the monitoring, the nurse, the doctor, other staff. It does seem that psychiatrists are motivated to do this monitoring, and it's more the obstacles that get in the way of good intentions. Sometimes problems communicating with the child or adolescent's pediatrician or primary care physician are obstacles. It should also be noted that some psychiatrists express concern about losing rapport with their child patient regarding the monitoring, especially blood draws, and this seemed to be particularly the case when there was severe mental health diagnosis and pathology. We just have to do a better job of educating our colleagues, patients, and families and the community of the risks, benefits, and emphasize that prescribing these medications, which can be enormously effective and helpful when prescribed and monitored correctly, can be very dangerous when they're not monitored properly with lifelong serious and significant complications. The bottom line, though, is it's just not responsible to prescribe these medications and not monitor them properly, regardless of the reason. The same way it would not be reasonable to prescribe a chemotherapy regimen for a cancer patient and not monitor this closely because the diagnosis is so serious or the person doesn't enjoy all of the workup and blood tests, spinal taps, etc. We do it because it's right and best practice. Remember, knowledge heals and can overcome these challenges and barriers. So how do we overcome the challenges? More manpower, so clinics need more nurses and staff so that psychiatrists can focus on prescribing the treatment and overseeing the monitor, but delegate to the nurse and office staff with mechanisms in place for adequate monitoring, reminding when testing is necessary, etc. As I mentioned, education is so important and leads to increased knowledge. This education should include detailed information about potential outcomes of treatment, the potential for lifelong serious complications, how they can be prevented and detected earlier to minimize their sequelae. Being trained and providing clinic staff with specific guidelines and algorithms for best practice guidelines, how to monitor, when to monitor, can also be very helpful.